year, according to the Centers for Disease Control and Prevention, the CDC, at least 1.7 million adults in the U.S. develop sepsis, and nearly 270,000 die as a result. It's also a main reason why people are readmitted to the hospital, and that's a major issue for EMS. Hello, everyone. I am Kevin Kelly. He's Paul Gerard. We hope you're having a sepsis-free day. We are Gerard & Associates. Check us out at www.gerardassociates.com. We are going to find the G&A SSR. Folks, that stands for the G&A Sepsis Summary Report. And did I tell you, we're talking about sepsis today. You're listening to the G&A Way EMS CQI podcast. We're on Podbean, Apple Podcasts, Spotify. Hey, Paul, do you remember your first sepsis call ever?
No.
You don't? All right, let me ask you this. Do you remember any sepsis calls? Any at all?
Vaguely. Yeah, right. I vaguely remember lots of them. They all seem to run together.
Yeah, but, I don't remember any sepsis calls per se either, or something that I was thinking, oh, my God, this is sepsis. We're going to go evolve into septic shock and that whole cornucopia of issues. I can't remember any one. I can remember some shootings. I can remember some stabbings. I can remember the case in either Fairhaven or Acushnet, the T-bone that took the kid's face off when the medical director was screaming, break the kid, break the kid. I remember those kind of calls. I also remember starting IVs on altered mental status patients that were warm and pink and dry to the touch, getting them in there, maybe having to give a bolus of fluid. And then watching the hospital staff attach antibiotics, but I can't remember any sepsis call that like a TV show would want to do a show about it.
You're not alone. Most providers might say the same thing, and it goes to the heart of what we're going to talk about today, because sepsis is not sexy. Right, gunshots. Yeah, you remember those because it's sexy, right? It's unusual, a lot of adrenaline flowing, interesting. Sepsis usually presents as little old ladies who have an altered mental status or something along those lines. So it loses a little bit of the sexiness compared to some of those other calls.
Yeah, I mean, it's not sexy, but in the panoply of being a paramedic detective, there is a treasure trove of opportunity to detect. And there's all kinds of signs, symptomology, and as like the CDC says, a huge problem. And we in EMS have an opportunity to head that off as a pass. So not sexy, but a significant problem. From an EMS perspective, what is sepsis?
Basically, it's a raging infection. All right, so it's a raging infection that can become life-threatening quickly, especially in risky populations, elderly folks, young people, people with compromised immune systems, that sort of thing. So, and the reason we probably don't remember any of these calls is that most of our heyday on the streets, sepsis wasn't a thing, right? It's only been over the last, 8-10 years that we've been making a big deal out of sepsis. So, that's part of it, is that we weren't really looking for it a lot specifically. And the problem is that a lot of people today are still not looking for it specifically. So it's going missed, going undiagnosed in the field.
Yeah, I can't believe how complicated sepsis seems to be from my perspective now versus when I went through paramedic school with, I think, the second or third edition of the Nancy Caroline book. And we got a tutorial on septic shock and sepsis in paramedic school during the shock chapter.
Right.
And that's where, and it was basically the low blood pressure, the, dry, warm skin, the infection, bump them up with fluids. Cause back then it was, a couple of large bore IVs, open them wide and a haul ass to the hospital. We weren't dicking around like you guys are doing now for 30 minutes,
Right.
So I jumped on the G&A website, www.gerardassociates.com. And Paul, I found a treasure trove of information that is on that site about sepsis. And I could not believe that warm, dry skin, tachycardia, low blood pressure, some respiratory, has now 13 elements that you got to be aware of in the compendium of shock assessment, treatment, and documentation.
Right. Yeah.
And that's
Go ahead.
that's the GNA sepsis summary report, the GNA SSR, Paul.
Right. We have a sample report on our website for one of the ways that we quantify sepsis type patients. So again, they can find that under the reports tab of the website. But yeah, that's it's become a bigger and bigger deal. There's one study by a respiratory magazine that stated that EMS providers deal with serious sepsis patients more frequently than STEMI or stroke patients. We see more serious sepsis patients than we see STEMIs and strokes. And yet it doesn't get the same attention that STEMI and stroke gets. And of those patients, 19% of them die in the hospital from their sepsis. So that means that a lot of the sepsis patients that we're transporting are very, very sick and will not do well and need early aggressive treatment in order to improve those outcomes. So there's a much bigger emphasis nowadays, not just with pre-hospital EMS folks. It's also a big deal in hospitals. It's considered a never event by the government in terms of reimbursement. If you're in a hospital and you contract sepsis in the hospital, that's considered a never event, and the hospital can get in trouble for not keeping cleanliness standards up, for example, or not recognizing early sepsis. So there's more pressure that in order to get the hospital to pay attention to this, because they're not always paying attention to this, one argument is, well, let's make the field guys screen for it, and then they can relay that information to the hospital and make sure the hospital is on alert so that they can aggressively treat these patients.
So it's funny you mentioned that, because a couple of things. Number one, we didn't really think about sepsis, but there were times that in the field we would start a line and then we would get a call from infection control, somehow blaming us because the patient had some kind of infection, and they wanted to, tack it to the IV that was done in the field, and not in the cleanly emergency department. But the other thing too is, it is a huge deal in the hospitals. It is a huge deal with insurance companies and Medicare, and it's a huge part. Sepsis is a huge part of a health systems compliance program. It should be a bigger issue with EMS, and it is for us. It is for Gerard and Associates. It is something that we have honed in on over the past 20 years, 400,000 calls. We know a thing or two because we've seen a thing or two. So this is a Gerard and Associates EMS CQI measure that we highly recommend. And while it's not on the National EMS Quality Alliance, the NEMSQA, while it's not a NEMSQA measure, I got to tell you, Paul, I'd rank it right up there in severity of risk with the use of lights and sirens by emergency vehicles. Would you not?
Yeah, oh, absolutely. And they're going to, I would imagine NEMSQA and other organizations are going to start jumping on board a little more in terms of measuring this because it's important. And field providers oftentimes miss the opportunity to identify and then treat sepsis patients. So that's coming. If your agency's not already paying a lot of attention to it, it will be in the not too distant future because the risk is so high for so many patients.
So let's get jiggy with it. Let's get in the weeds. Let's be dirt dogs. Let's have at it. The sepsis summary report, the 13 elements of the GNA SSR. Break it down for us.
Yeah. Well, it's basically that document is basically kind of a protocol driven. Here's the things that you should be considering for sepsis patients. And what's unique about our report is that we don't, and we do this with a lot of reports, is we look at not just the patients that the provider says is septic, and that we're therefore treating it. There's a line at the bottom of that which tallies should have been identified as possible sepsis as well as was identified as possible sepsis. And really, that's where you capture the problem calls where people just ignored sepsis as one of your differentials and went with whatever the initial complaint was. And that's one of the biggest problems we find, Kevin, is that field providers, they'll show up to a little old lady's house and, the family says, yeah, she's got a slight altered mental status. And they'll say, oh, okay, well, if we got an altered mental, that's the protocol we're going to work under. And they don't go deeper. They don't dive deeper to determine what might be the cause of that altered mental status. And it can be all sorts of causes. And sepsis for some folks is not very high on their differential list. So we try to get people to pay attention to that and to identify identify every patient who may be potentially septic and then deal with it appropriately.
All right. So working on the call, we're working. You and I are working together on a truck. How are these calls typically dispatched? I mean, they're not generally, unless you're in a nursing home or a skilled nursing facility, your random citizen isn't generally calling up and saying, "Hey, I have sepsis. I need
septic,
to rise up. I'm septic."
Right,
yeah.
Right. Yeah.
So how do these things come in? What's the evolution of the call like?
There's a variety of different ways the call can come in because sepsis can present in a variety of different ways depending on how bad it is. So the most common is it comes in as an altered mental status. So the patients, whether they're elderly or not elderly, the patient's got some form of altered, and that's how the family calls it in when they call 911 to ask to get mom transported to the hospital. So that's how it gets dispatched out. On occasion, we'll see some other stuff, but the thing that is interesting about sepsis is that it can be a secondary issue, and everybody gets honed in on the primary problem. So we've seen all sorts of patients who are having strokes and also septic. They were hypoglycemic and also septic. Drug overdoses who are also septic, possibly from dirty needle use or something. But so you get there and say, oh, this is an overdose. This is a diabetic. There's my problem. I'll fix it. And they really don't go deeper into looking for relevant signs and symptoms.
So what do they got to do? I mean, so you're reviewing the reports. Your reviewers are seeing what they envision as a patient that at least should have been screened for sepsis.
Right.
They're not seeing the cues. They're not seeing the evidence, the data in the run reports. That's jumping off at them. So they flag this. Then you sit down with the reviewer and you start going through it.
Right. The auditors will flag in on the things that jump out most that you should pay probably most attention to with any of these patients is if they have a potential infection source or an elevated temp. So if they've got one of those two issues on patient contact, then the auditors by definition will start looking around in the report to see if there's other criteria that would make them potentially septic. So they document that the patients had recent surgery, for example. And again, sepsis can be a byproduct of a variety of different mechanisms: pneumonia, UTI patients who have catheters inserted, long-term that eventually evolve into an infection source. So there's a lot of potential causes. And what we see is the providers will get on scene and they'll again jump onto that first complaint and start to address and fix that. And they may not even consider sepsis as an option. But whenever an auditor is reading the report and they see, oh, patient's complaining of an elevated temp, or family says patient's got an elevated temp, or nursing staff at the nursing home says it, then they start to say, all right, this could be a sepsis patient. Let's see how the rest of the assessment shapes up and whether they did a proper assessment to determine whether it was sepsis. And that's where it goes astray. That's where people go afoul, is that there isn't that additional information that they should be questioning in order to determine whether the patient may potentially be septic or not.
So your auditors are seeking or looking for evidence that the patient was assessed for a possible infection. That's right?
Correct. Yep.
Yeah.
Yep.
And they're also looking for evidence or clues, cues, whatever, that the patient had a body temperature greater than 98.6 or less than 98.6 or greater than 100.4 Fahrenheit. Is that right?
Yeah, there's different criteria depending on the protocol, but some protocols, they say that under 96.8 or above 100.4 or 100.1 in some cases. So the numbers sometimes are a little different protocol to protocol, but basically it's not just a hair under 98.6. It's more of that profound low temp or significantly higher temp, over 100 certainly, if not 101. So that's your temp criteria for the most part. And anytime you have a patient with an elevated temp, you should be thinking, is this sepsis? Is sepsis what's possibly going on here as part of what I need to assess them and treat them for?
Right. Heart rate greater than 90 beats per minute, respiratory rate greater than 22 beats per minute is common in some of the protocols, and red flag light bulb goes off. That in order to get that heart rate and that respiratory rate, all of that, you got to be bringing your equipment to the patient's bedside. So these,
you're going to be assessing them.
Yeah, I mean, you got to, right. I mean, I know it's common sense, but we've done a couple of shows now where bringing equipment to the scene, seems to be an obstacle. So
Right.
get your equipment to the scene so you can at least take the heart rate. Yeah, you can bring your stethoscope, all of that stuff.
Right.
Element number 5, systolic blood pressure or a mean arterial pressure less than 65. Is that what your audit
Yeah.
is looking for?
Well, blood pressure under 90 and a mean arterial pressure under 65. So we're looking for all of those categories. And that's why that report that we have, it basically mimics those questions. Did the patient have that? Yes or no? Or was it assessed? Yes, no, or not applicable? That sort of thing. But that's part of the reporting that we put out to see if they met any of this criteria. The reality is the protocol usually states that there's something like any 2 criteria on that list that you just mentioned qualifies them as sepsis. And the problem with that is you can have an elevated pulse rate above 90 and an elevated respiratory rate above 20, 22, whatever your protocol is. That's 80% of our population, right? Just,
right.
just the fact that EMS shows up, patients get anxious that you get all these guys tripping through their house. So you can easily have an elevated respiratory and pulse rate, and they're not significant increases. They're quite modest. So, and I think that's one of the things that people go wrong is they don't want to call a sepsis alert for a patient who meets those 2 criteria without having something a little bigger to hang your head on. So we counsel them routinely. Okay, so you got those issues. That's great. But you're really looking at the complaint, and then you're looking for the infection source of some sort and the temp. And if you've got one of those 2, and the third would be end tidal, an end tidal value under 25, 26 or so, are high indicators that the patient's septic. So those are the more important ones. And then the other stuff is just gravy. Oh, yeah, they also have an elevated pulse rate and an elevated respiratory rate.
Now, as you know, I haven't been on the truck for a while.
Right.
But so correct me if I'm wrong. Things might have changed, but with heart rate, respiratory rate, and blood pressure, checking those isn't one and done, right? I mean, this is something that you periodically throughout your 30 to 40 minutes stay in the patient's house because, we got to work them up the bill. It's no longer scoop and screw. We're talking about obtaining multiple sets of vital signs and documenting evidence that you are continuously assessing the patient per protocol.
Correct.
You said these calls frequently come in as onset of altered mental status, and I noticed that it frankly is one of the clues that you're looking for, and you're looking for documentation whether the altered mental status was new onset or whether it has increased as the result of some previous diagnosis of altered mental status. But you're looking for an ever-increasing concentric circle of evidence on the onset and the evolution of altered mental status, right?
Yeah. So again, this goes back to the thorough assessment thing, is that one of the things you want to know is how long has this been going on? So if you have a patient who has gradually been having an altered mental status over 2, 3, 4 days, then you're really going to be worried that the sepsis might be more advanced, because remember, your low blood pressure as a sign of sepsis is a late indicator or later indicator. And if you're waiting to see the patient be hypotensive, you're waiting too long. Those patients don't do well if they become hypotensive as a result of their sepsis because it went undiagnosed and untreated. So don't wait for the blood pressure to be low to pull the trigger and say this might be sepsis. You have to have a high index of suspicion from the other stuff that we already talked about to show that cause. But yeah, again, getting that thorough documentary evidence, both doing it and getting into the run report record is vital.
Serum lactate, you're going to have to help me with that one.
All right. So serum lactate is one of the ways that in hospitals they diagnose patients. Usually anything above 4 millimoles per liter of serum lactate elevation indicates potential sepsis. Serum lactate and end tidal are inversely correlated. So as your lactate numbers go up, your end tidal comes down. So if you have an end tidal of less than 26 or 25, you probably have a serum lactate of over 4, and that is dangerous for the patient, regardless of how they're presenting to you. They could be alert and oriented. They could look fine. They're rock solid blood pressure, but they had surgery a week and a half ago, and they've got all sorts of oozing and pus coming out of the surgical site, and it's red and hot to the touch. There's your infection source, and just because they look relatively stable, if your end tidal is low, you've got to be worried that this patient's further along than they may appear. So get on them quick, get that IV started and start getting that fluid into the patient immediately. That's really the main thing that we can do pre-hospital to help offset the progression of sepsis.
Chronic assessment and fluid boluses per protocol. Is that right?
That is right. Yep.
Okay.
Yep.
And boluses. Let's say the bolus doesn't work. What ought we be considering if the fluid challenge doesn't work?
Yeah, other pressure support measures. So dopamine, epi, norepi. Most protocols have one or more of those drugs in the protocol. So if fluid doesn't work, then you need to give them pressure support. But that again is for the hypotensive patient, and hopefully you're not waiting for them to be hypotensive to start treating them. One of the common errors we see, Kevin, is, and this is a kind of a big one. This happens very, very frequently, and I'm sure it happens in most EMS agencies, is when providers will recognize sepsis. They'll put a line in the patient. They'll give a sepsis alert, all good, but they don't give their fluid bolus. And when I say to them, hey, how come you're not giving a fluid bolus? They say, well, the guy's pressure was really good. In fact, he was a little hypertensive. It was 140 over 90, or something. So I held off. And that's not correct thinking. Even though the pressure looks, you're not giving the fluid for pressure support per se. You're giving it to help dilute the blood, the serum content, the metabolic content in the bloodstream, which is what the sepsis is doing, causing that concentration in the bloodstream. So you're really trying to offset and dilute that patient so that the sepsis doesn't take over and rage right through the patient.
Now, we're not walking these patients to the ambulance, correct? I mean, some
people are.
Yeah.
Yeah, look at the news. Have you seen the news lately?
Yeah, I have. I'm a big fan of Ring camera video, as you know.
Yeah. Right.
I spend a lot of my life. I spend a lot of my life looking at body cam and Ring camera video. All right.
Yeah.
So, vulnerable patient population, you got to control the patient. Their altered mental status, so your ability to control them is probably a little easier than not, depending upon how amped up they are. And generally speaking, these sepsis patients aren't what you would label as excited delirium. They're really sick people that need very vulnerable and need our assistance moving them.
Right.
You want to document how you move them as well. Make sure that you have that covered for risk purposes. Again, they're vulnerable. They trip, they fall, their altered mental status. Document how you move the patient. Elements 12 and 13 of the 13 elements of the Gerard and Associates sepsis summary report are: when was the hospital notified and how was the hospital notified? And I think this is excellent, but explain why that's important to document on your run report versus just relying on dispatch, that kind of thing.
Yeah. So again, sepsis has become a big deal over the last few years. And because of that high mortality rate that you mentioned, and it's happening in hospitals everywhere, in spite of best efforts to get hospital personnel to pay attention to potential for sepsis, they have the same problems EMS providers do, where they get sidetracked by the patient's complaint or some other clinical issue going on with the patient, and they tend not to look for sepsis until it becomes bad, or they get labs back and they see their lactates are really off, or they see something. And by then it's starting to be too late, especially in that vulnerable population. If you're just then identifying it, those folks don't do well at all. And there's a high morbidity mortality rate in those folks if there's delayed interpretation of those numbers to determine whether sepsis is present. So what they said was, well, maybe what we can do is we can have field providers help with this problem. If they can recognize it in the field, give us an alert on the way in. So A, we don't miss it, but two, just like STEMIs and CVAs, we can do a little prep work in-house to make sure we have everything we need to get going. Then that will speed up the treatment process and therefore decrease morbidity and mortality. So, when one person once said to me, that they don't like to give stroke alerts because they don't feel that the hospital does anything with them. Unlike stroke or STEMI patients, the hospital goes into high-ish gear, hopefully, when you call and give one of those alerts. But when you call with sepsis, because the hospital doesn't have a lot to do, they're not clearing the CAT scan table, they're not calling the cath lab and telling them they got a hot one coming in. People are not doing all that level of stuff. Sometimes the field providers get the impression that the hospital is lackadaisical about it. And so it's like, well, they don't take it serious. I'm not going to take it serious. It's not that big of a deal. So they tend to They tend not to give their notifications because they feel the hospital won't jump on it as aggressively as they should. Again, that's wrong thinking. You got to do your job, and then that's up to the hospital to do their part. And you don't know what they're going to do when you get there. Just because the first 10 or 15 minutes while you're there, they might not seem excited, doesn't mean that they're not getting labs and checking for serum lactate levels and those types of things to determine whether to treat this patient. So don't get fooled by lackadaisical healthcare providers that don't seem to be taking this too seriously.
Yeah, that's true. And as you said in the opening, it's not very sexy. And as an adrenaline junkie myself or ourselves, it's hard to get an erection when you're amping somebody up, getting them to the hospital, lights and sirens, just to get a bolus of penicillin. So, that's basically it. And but these are acutely sick patients. They need serious assessment. ICU like critical care paramedicine like assessment en route to the hospital. And in order to cover all of the risks, there has got to be detailed documentation about the evolution of the call.
Right.
Final thoughts on sepsis, Paul? It's not sexy, extremely important. We have an incredible opportunity to save lives, decrease morbidity and mortality. What are you thinking?
Well, I'm thinking that there's a few issues here that people also don't think of. And so one is they sometimes don't take a field temperature on patients. In fact, it happens fairly frequently. And when I say to people, hey, how come you didn't get a temp on them? More often than not, they'll say something to the extent of, I don't trust my probe on my monitor. It always gives bad values. I don't trust that type of thing. So, if you have to have a backup temperature, a temperature acquisition piece of equipment, then you need to get backups. So that's one thing people tend not to do. They also tend not to shoot 12 leads and do blood glucoses. And again, they're not necessarily in the hypoglycemic protocol. Even if you know it's sepsis, the moment you step onto the patient, the side of the patient's bed, and you're assessing them, you still want to double check your blood glucose levels. So doing some of that secondary ALS stuff, assessment stuff is important. It helps build the story. And end title is a big one. And interestingly, when we score calls that the providers didn't do end title on a potential sepsis patient, we look at that as being important for the reasons we talked about a few minutes ago. But a lot of medical directors poo-poo it and just go, yeah, end title, okay, and they look stable. They look relatively stable, their pressure and all, and they fall into the same kind of traps that the field providers do. And in fact, this is probably one of the reasons why patients get underdiagnosed and treated in the hospitals, is because even hospital staff, including physicians, are not taking this as seriously as they should. But we have a large number of medical directors who, when the rest of the sepsis call went well and did everything they should, and the auditors, kind of score it as a 3 or 4 or something and say, well, I scored it high because they didn't do an end title, the medical director's like, he's not so concerned. But it's a great tool to use.
Would I know who that medical director is?
Nope. No, okay. I don't think you would. Well, I don't know about that medical director. Not our guy, I don't think.
All right. Okay.
But other guys, other people. So, but that lulls the provider into a false sense of, this is not important, I don't need to do it. And it is very important. So if you have a borderline patient that you didn't treat with sepsis, and they've got borderline complaint, borderline temperature or infection source, and you're not sure, getting that end title is another piece of data that you can accumulate that'll help you to make that determination. And if you don't do it and you miss the sepsis diagnosis, you can bet that anybody investigating that call downstream is going to want to know what your end title numbers were. And did that indicate, would that have indicated that the patient was possibly septic and that's why you missed this? So I think it's an important piece of the call. I think it's a valuable tool. I think it's very helpful. The flip side, and I think one of the reasons the medical directors some medical directors are a little soft on that, is that you can have low end titles from a variety of factors. And in and of itself, it doesn't mean the patient's septic, but you have to, like every other assessment indicator that you have to take the totality of the entire assessment and all the pieces and put them together and then say, okay, here's where I think we have issues that we need to treat on behalf of the patient. So yeah, make sure you're getting blood glucoses on as soon as you think this is sepsis. Make sure you get that blood sugar. Make sure you shoot that 12 lead. Make sure you get end title on the patient. These are all just good, solid clinical care. And the other is obviously give the hospital a notification. And we see oftentimes providers will identify sepsis and not give a sepsis alert. And again, when I ask them why, they say, well, they don't do anything with it anyway. Or they say, this patient was borderline. I wasn't convinced fully they were septic, so I didn't call it in. And that's wrong thinking. If they meet those criteria, those criteria that we spoke of earlier, especially with the temp and the infection source and the low end title, in addition to the pulse rate, respiratory rate, and what have you, they can, if they meet qualification, you should really notify the hospital of that so they can determine whether they need to take aggressive action on it. So what you can do though, and what I tell providers is you can qualify those answers, right? You can say, hey, listen, this patient meets sepsis criteria because she's had an elevated temp for the last 2 days and been on Tylenol. She's got an elevated pulse rate, elevated respiratory rate. Other than that, we can't really determine any source of potential infection. I'm not sure if this is sepsis, but that meets my sepsis protocol criteria. So I'm giving you a sepsis alert. Do with it as you will. And at least you've done your job. But you've also kind of indicated to them that you're maybe a little skeptical that might be what's going on. So it's okay to have that discussion with the folks answering the phone at the hospital when you give your entry note.
All right. I think we covered it well. How about you?
Yeah, I think so. I think those are the common flaws we see, the common issues we see. So if you're a paramedic, pay attention. And I want to throw in one other thing is we see a very high miss rate for EMTs prior to paramedics getting there.
Okay.
And we see a number of calls where the EMT has that same vague presentation and they don't dispatch ALS because they feel like, well, I don't know what the cause is here, but they're not that bad. They look pretty solid, vitals wise and that sort of thing, and even mentation wise, perhaps. But if they've got that infection source and there's some other complaint, presumably that's why they called you, you need to dispatch ALS if indicated for those patients. And the reason with EMTs, again, going to the root cause, is a lot of them are not comfortable in identifying sepsis. They don't want to be wrong and activate ALS if ALS is not needed. In some systems, the paramedics bitch out the EMTs if they call them when they because they don't want to work that pay. He's not that bad. You didn't need to wait for me, kind of stuff. But irrespective of that, EMTs probably need a little bit of help with putting it on their radar screen that they should be looking for potential sepsis because that is an ALS patient, a septic patient. So those are some of the tips and things that we see that often go unnoticed or undone for sepsis folks. And field providers can go a long way in making sure they're doing those things. QA folks can go a long way in looking for this stuff when they're auditing calls as part of the CQI process. Make sure that people are doing thorough exams on patient who have at least an indicator for risk. So if the patient says, I've had a UTI for a week, and then don't get into potential for sepsis assessment material, your CQI folks should flag that and should have that discussion with the providers that they need to consider sepsis as an alternate diagnosis.
And I'll just add, don't pipper sepsis patients. These are not the patients that you want to, say, well, gee, we could take you to the hospital. There'll be a couple of grand.
Go see a doctor Monday.
Right. There's an Uber Eats right down the road. Yeah. Maybe we can get them. Yeah, that kind of thing. No pipper and sepsis. All right. Well, I think that's a wrap on sepsis. It's all about the assessment, the documentation, and really it's all about the Gerard and Associate Sepsis Summary Report. Check it out at www.gerardassociate.com. Check out the 13 elements of the SSR. For Paul Gerard, I am Kevin Kelly. Stay safe, stay in the fight. Godspeed. Thanks for caring. Thanks for listening, and we're grateful to you.
See you soon, everybody.
On 5.